Welcome to the podcast, Ageless Rage, where we talk about everything beauty and health related. And today I have my esteemed guest, Dr. Zhang-Nunes, a ocular plastic surgeon and reconstructive surgeon from USC. She specializes exclusively in ophthalmologic surgery, and as well as surgery that has to do with plastics around the eye. So it's an interesting specialty. It's both ophthalmology and specifically plastic surgery around the eye. And Dr. Zhang Nunes is director of oculoplastic surgery at USC, and she's an associate professor of clinical ophthalmology. She earned her undergraduate degree at MIT and her medical degree at Hopkins, and then she completed her ophthalmology training at UCLA as a prestigious 2-year fellow. She went on to train in aesthetic oculoplastic surgery, such as ocular depressions and decompressions and endoscopic forehead lifting, as well as laser and light therapy, neuromodulators, facial volumization treatments, and she's the founder of Cutting Edge, an ocular plastic surgery surgical skill course, and is known for research in the dissolution of various fillers to improve the safety of aesthetic treatments. And she has training in periocular laser and light treatments, as well as ocular rosacea and dry eyes. And she has done extensive research on the application of other technologies such as ultrasound and surgical outcomes and radical and racial factors, I should say. So welcome to our podcast.
Well, hello. Thank you for
Hello.
such a nice introduction. Yeah, as you see, I enjoy doing a lot of different things, and it's nice to be in such a broad specialty where I can dabble in all the different ranges that we do, functional to cosmetic. Yeah.
So tell me, Doctor, how did you decide to pursue this career? Specifically, how did you get to ocular plastics? Because that's a very, very detailed subspecialty of medicine.
Yeah, it's very interesting. So in medical school, I actually originally thought I was going to do something in the neurosciences because I was a brain and cognitive sciences major at MIT. And in medical school, I was doing some research in neurology and actually did a Howard Hughes research year in Alzheimer's disease. And we were using mouse models, and I was doing microsurgery on mice and basically making a window into their brain using, keeping them alive, making a window into their brain and using a portal to look inside their brain with confocal microscopy. And I just remember really loving that microsurgery, being able to see in detail through the microscope what was happening live in a mouse brain. And I was just enthralled. And I thought, oh, what field allows me to do microsurgery? And that's how I happened upon ophthalmology.
Wonderful.
And and so there was 4 years of ophthalmology, and the most surgical of the subspecialties in ophthalmology is oculoplastics or oculofacial plastic surgery. And so whenever I was in the operating room if there's an oculoplastics operating room going on, that's where you'd find me. I'd make my way there, and I knew I was drawn to it, and that's what I'm doing now. So it's great.
Wonderful. So what's the most rewarding part of what you do?
Oh boy. Several things. I mean, some of it is just being in the operating room and getting to fix people, whether it's for functional reasons or cosmetic reasons, making people see better, look better, and feel better. And then getting to be on the other side of it after they heal from surgery, or whatever procedure I'm doing for them, and just getting the reward from their satisfaction and just seeing their lives changed for better, whether it's just quality of life or we even occasionally get to save a life, take out a tumor and save vision and all those things. So it's quite the wide variety I get to do. And it's just so gratifying to, have that grateful patient just be so happy at the end of it,
Sounds like your gratification comes from doing a lot of different things that make meaningful impacts on people's lives.
Yeah. And also getting to teach. I'm in a role where I get to teach residents, fellows, medical students, and seeing them blossom and get to learn how to take care of patients and just things, the way things click, and just seeing that next generation come up is great
So,
as well.
so what would you say is the most, how would you describe exactly to people what an oculoplastic surgeon does? What do you
That is a
exactly do?
That is a very good question because most people don't know and don't understand. So thank you for asking that. And it's just really broad. I was trying to figure out how to make this more succinct, and I'll tell you, I asked ChatGPT to summarize what it thinks us oculoplastic surgeons do, and I thought it did actually a good job of summarizing, the key areas we work on. It's mostly eyelid surgery. That's probably our bread and butter. But we also do orbital surgery, like big tumors, fractures around the eye, removing tumors. Even, I had someone consulting me about taking a biopsy of an optic nerve, and thyroid eye disease is something we treat a lot as well. So I'm kind of going over the functional stuff first. We also do tear duct surgery, all those watery eyes that tear drain doesn't work. And then we have the cosmetic and aesthetic half. So we have I do a lot of neuromodulators. Probably my most common procedure is Botoxium and Dysport, our neuromodulators. And we do the fillers for facial rejuvenation as well, and laser lights. Not all of us do that part, but I was fortunate enough to train in that. And then the surgical procedures, obviously eyelid lifts, the upper and lowers, the forehead lifts. That's probably my most common procedures. And then we kind of treat the whole face as well. So a lot of my colleagues do facelifts. I train in facelifts as well. I don't do that as much. I like to I pride myself in doing what I do the most of, and because I want to be the best and super subspecialize in this one area. So I'll partner with my facial plastic surgeons. We're going to do combo lower face and upper. Some of my colleagues do the whole thing themselves, so they'll do upper and lower and even neck. And so it's a wide variety. We have functional and cosmetic and reconstructive all in one.
So would you say that the ocular plastic surgeon has a unique plastic surgery perspective because their main thing starts in and around the eye area and then
Yep.
goes from
Goes
there and
out.
includes
Yep.
the rest of the face, whereas possibly a general plastic surgeon would think holistically for the whole body and not necessarily
Yes.
focus around the eye. So it's a good
Right,
way to.
right. So yeah, for example, I think for me, it's been very helpful to have the ophthalmology background for, let's say, being able to treat dry eyes, which is a big common side effect of blepharoplasty surgery. People will have too much surgery, too much removed from their upper or lower lip blepharoplasty, and they come to me, their eyes can't close or they can't blink right. They don't. Their eyes just get more dry, and they're miserable. Dry eye is actually one of the most common complaints, especially I'm in Los Angeles. It's super common here. And anywhere where it's not really high humidity is probably a very, very as you get older too, very common to get dry eyes. And I can even go into what causes dry eyes is that I have a whole lecture on how we as oculoplastic surgeons interface with dry eyes by first knowing how much tissue to leave behind. Preservation blepharoplasty is something I focus on, preserving the muscles of blinking, closing the eyes. Uh, because we'll see people who've had like a blepharoplasty 20 years ago, and initially they were fine. They thought they were great, but now they're just miserable because too much muscle was excised and they can't blink and their eyes are always red, watery, and uncomfortable. And so since I get to see that side effect, I'm much more cautious in when I do blepharoplasty to try to minimize that side effect and also simultaneously treat the dry eye as well. So that's why I kind of evolved my other therapies, like the laser light treatments that I do to help treat dry eye, the meibomian gland dysfunction, all of that. And I like to be able to treat the whole patient and kind of put that all together. Prevent that's part of my evaluation for a blepharoplasty, for example. I'll say, I need to know your baseline dry eye status. Do you have it? Do you have the potential for it? If so, I'm going to be more careful in how I do the surgery and plan for the future.
So when you talk, do you think most patients, when they go and get a blepharoplasty or eyelid surgery, they're fully aware of this eye dryness risk factor? Do you think they're well versed in that?
Oh, absolutely not. And I think that's a major problem we have in our field. Because I mean, I see people go off some, or they end up coming to me with their eyes. You know, the corners is actually a very tricky part of surgery and being able to tighten the eyelids appropriately because it's a challenging area to kind of get right. And sometimes they're not tightened, and then the eyes will droop down, like it pull if you especially if you remove too much skin under the eyes, they kind of pull down in a way. And you can imagine you just do this to yourself right now, like pull your eyelid down, you know, from the side of your eye and just kind of hold it there for and you start to feel how dry the air is hitting it, right? And some people just live like that all the time because their eyes can no longer close. So they are some of the most miserable patients who've had it's kind of a post blepharoplasty dry eye syndrome that we're seeing more and more of now. And it is something that I feel like is underappreciated. And that's why I appreciate the chance to kind of talk about it so that we can help more people understand what to look for, how to watch out for and prevent this problem.
One, great. So when you look at somebody's eyes, just in general, tell me the things you notice the most.
Well, yeah, you know, I'm putting myself in the kind of like, you know, going to a party and I tried to take my, you know, doctor hat off sometimes, but sometimes you can't help notice when, you know, the eye might be obstructing and drooping. I wonder like, how well are they seeing? How are they driving if their eyes can't open well or, and you know, you look to see how well the eye is proportioned within the eyelids in terms of like how where the upper lid is covering the what we call the cornea, which is the
Mhm,
overlying the iris, the colored part of your eye.
mhm.
You want to see that it's about, you know, 2 millimeters above the pupil at least. And then the lower lids, what people don't realize is you want the lower lids to also be right at the bottom of the cornea, the colored part of your eye, maybe like a millimeter higher even, so that you get better protection of the eye. And you'll see a lot of people as they get older, the lower lid doesn't even touch the cornea anymore. It's lower, and so that those eyes are much more likely to dry out. So
Mm.
you know those are things
Those are the
I
big.
notice. And also, you know, I notice whether their brows are falling into their eyes, and then I want to give them a little Botox with lift and brow lift at the same time. So,
And when you see people, I'm sure you can't help but notice prior blepharoplasties, prior surgeries.
oh yes,
And when
yes.
you
So,
look at that, what is the thing that stares you in the eye the most? What do you notice most about most blepharoplasty surgeries?
well, I can always tell if they've had a not so good one. Meaning, so the corners of the eyes get rounded. I don't know if you've seen that rounded corner look,
Right.
and you can always
I see
tell.
that. I see it.
Yes,
And they
yes.
have
And
like
then
sometimes a little like a little line that doesn't go away. That's the corners of the eyes.
yeah, and well, yeah, the rounding and just kind of the kind of a strange alignment of that corner because the corner is actually one of the hardest things to get right in the surgery. I remember it took me like at least 2 years in my fellowship before I feel like I got a good handle. And even after fellowship, you know, we do 2 years of basically eyelid surgery every day, all the time for for a while. And that corner is still one of the last things I feel like it took me a while to do very well, because you have to get in and out. You know, there's a whole 3D alignment that you need to understand, and everybody's is different. So
And
I see that pulled down. I see the scar sometimes, and my goal is to make it look like my post blepharoplasty patients should never look like they had blepharoplasty. That's my goal. Like you should not be able to tell. You want to leave them natural looking, no scars, no rounding. It looks like they just got a good night's rest.
so
That's my goal. So
when you walk into the room 6 months or a year after their surgery and you see them,
yeah,
you can't tell right away.
exactly, exactly. So that happens all the time when I walk into the room and I'm like, hi, what are you here for? I have to look up my notes and oh, I did surgery there. I did not realize. So I am happy when I can't tell where I've been.
Well, that's
And
where you
and I
give
had to
yourself.
literally look at my notes and on my operative report to see exactly what I did. I'm like, oh, I did that. Oh, wow, I can't even tell.
Well,
So
that's very
that's
reassuring,
my
isn't
goal.
it? It's probably the
Yeah,
most reassuring thing.
yeah, yeah. That's when I pat myself on the back.
Well, that's what
But I
you
can't.
should, because and then and they don't have any dry eyes, and then and you can't tell, so that's the perfect
Right,
situation.
right. And then those are the happiest patients. They just are just happy because they not only look better, they see better, and they feel better. Right. So
Good.
that's my goal.
So, in general in your ophthalmology or your ocular plastic practice, what are the three main reasons people actually come to see you and or referred to you? What are the top three things that people come to you for?
Number one is definitely droopy eyelids, right? That's probably the thing we're most known for. I have to say ptosis repair. So ptosis spelled Ptosis. Some people will say ptosis, but it's just ptosis. And it means just droopiness, really. And so eyelid ptosis is probably one of the hardest things to treat and get right. And that's actually one thing that even general plastic surgeons or other people will do blepharoplasty, meaning they'll remove extra skin or fat around the eyes, but they don't feel comfortable doing ptosis surgery because that's when you have to get down to the eyelid lifting muscle and contour it, tighten it in a way that you have about a couple, sometimes a half millimeter of wiggle room to get right. And so that's probably the most common thing, like, which is, and it's harder to do. And it takes kind of years of kind of honing, getting a sense of how to tighten an eyelid on the operating room table. I actually have them wake up for a little bit of that portion so that I can line up the eyes as well as possible to get that. Now, that's kind of an external approach. I'm probably getting into the weeds a little bit here, but there's also different ways to do it. You can do it from the inside too. And so every patient I look at, there's a whole so much that I'm thinking about and deciding which is the right ptosis surgery. The other things that people refer for include thyroid eye disease, which is like bulgy eyes. It's an autoimmune disorder that causes bulging of the eyes, retraction of the eyelid. So it's the opposite of ptosis. So the eyes are super dry and uncomfortable. They have the red, bulgy eye picture. I think there's probably been more awareness of it now because there's a new drug that came out that can treat that well. And probably the third, I don't know. Then the third is a mix of like drooping lower lids, inturned eyelashes, the entropion, orbital fractures, tumors, tear duct problems. So it's a wide range. And then in terms of aesthetics, so those are mostly the functional referrals. The aesthetics is people with eye bags. The eye bags is the most common aesthetic complaint I get, and we can address that either by surgery or by fillers, and that's a whole nother discussion as well. The options there.
So, tell us about blepharoplasty and tell us how do you know tell us what it is and tell us how do you determine if somebody is a good candidate for surgery.
Sure. I mean, there's upper and lower blepharoplasty. Do you want to for
Just
both?
to tell just tell people what it basically is and just tell them how do you determine if somebody's a candidate for it.
Oh yeah. I mean, blepharoplasty just really means eyelid surgery, and if you have excess skin or excess fat around the eyes, that's probably a person that's a good candidate for blepharoplasty. And our anatomy changes over time, where as we're blinking, we gather excess skin, right? And then we get
Hmm.
the hooded lids. The lower eyelids get more wrinkly as we lose the collagen and elasticity in our skin. We also, the fat shifts as well as we age. So you have the fat above the lids and below the lids and all around the eyeball in the orbit. And what happens as you age is you actually lose fat in the upper. So, and you get more of that superior sulcus hollowing, right, above the eye. and then the fat shifts lower, gravity makes everything go down, right? And it shifts down to below the eyes, and then you get the fat bulge, the eye bags. And the reason they come out as bags is because there's a ligament that holds it in place, the orbital malar ligament, as well as the zygomatic cutaneous ligament. Those ligaments kind of trap the fat in that space so that they form that bag that you see, and the
And
tear
so,
trough area.
and how much is bone loss a factor? Is people with osteoporosis
Oh.
at a higher risk? Is that a big thing?
I don't,
Postmenopausal?
I don't know if we've studied exactly the amount of demineralization of the bone per se, but we know that there have been studies where they've looked at people's orbits as they age, and the orbits actually shift, they widen, and they shift out and down. And then the bony changes in the cheek, it shifts inward. You get malar protrusion. So you kind of get a flattening of the face. You lose that apple of the cheek look, the OG curve, and you get this flattening of the cheek from the bony changes. Everything kind of shifts down and kind of out. And you think, that triangular optimal, like the reverse
Mhm.
triangle with the top of the head being slightly wider than the lower. And because of gravity, everything shifts the opposite way. You get that reverse triangle where the top of the triangle or the top of the head gets thinner, and everything widens at the bottom. So the same thing happens in around the orbit and the cheeks.
Makes sense. So when somebody's looking for surgery around the eyes, what should patients look for in choosing a plastic surgeon or specifically an oculoplastic surgeon? What should they be looking for?
Really, I think they should be looking for someone with experience in that area, and somebody with that understanding of both the possible medical side effects as well, like just being how to first protect the eye. If you're doing surgery around the eye, you need to know how to protect the eye, right? Because that is a very vital part to our quality of life. And so somebody with experience, somebody who understands the anatomy intimately. For my subspecialty, we have a society called the American Society of Ophthalmic Plastic and Reconstructive Surgery, or ASAPers. The short name is now the Oculofacial Society, and those of us in the society have probably the our goal is to kind of improve the standards of our subspecialty and make sure everybody that is going through training now has the full breadth. It's a 2-year fellowship, not just 1 year back in the olden days, and having the full breadth of surgery, but also having the ophthalmology background to know how to best to protect the eye. I think that is somebody that I would trust more for surgery around the eyes.
So a lot of times patients will ask me who should they look for, and I always say, well, I like the idea of going to somebody who's an ocular plastics who does this type of surgery all day versus a general surgeon, general plastic surgeon. Would you say that that was a safe bet that I would advise that? I think that's a safe
Well,
way of putting
yeah,
it.
yeah, that's my biased opinion, of course, as well, from my experience.
I mean, I just think it's always a safer bet to choose somebody who does one type of
Yep,
surgery and does a lot of it all day long
exactly.
versus somebody who is going to be a generalist with plastic surgery.
Right, 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 exactly. And yeah, you want to understand the whole, and that's why we want to understand the whole space around that area.
Um, and even that would apply to choosing an oculoplastic surgeon over just a general ophthalmologist too, because I think in special cases you would probably have more experience and expertise just because you've more focused on that. When you say that to be true?
Exactly. Yeah, and that's where medicine is going, I think, these days is we have to subspecialize a lot to really be the best at what we do. And, that's why I chose to do that. And, I have to be honest, I really enjoyed cataract surgery as when I was a resident, but, I gave that up so that I could really focus on the surgery of around the eyes
And you
and
wouldn't,
the face.
and you wouldn't do cataract surgery these days because your
Right.
specialty is something else now.
Exactly. Yes.
Hmm.
I would not trust. I mean, unless it's desperate, I would not trust me to go inside the eye and do cataract surgery now. When you're not doing it every day all the time, it's not you're not as good at it anymore.
I
So
I agree. So what are the biggest risks with oculoplastic surgery? Tell us, you mentioned the dry eye. What else is the big
yeah.
risks?
Oh gosh, I mean, we had a case report of even just, what we think of as the simplest surgery, internal ptosis repair, where somebody went and unfortunately stabbed the eyeball as they were doing that surgery and punctured it, and what we call an open globe, meaning the and the eye is so refined in particular that any puncture is of the eye is can be disastrous, right? It's very hard to repair once there's been. It's not like you cut your skin and it'll just fix itself. The eyes, and if you actually go through and through, the cornea or the sclera, you're going to give yourself it'll leak, and the cornea has to be super clear, and if you have anything that violates it and it scars at all, that really can affect your vision. If you go through the sclera, you're going to get retinal detachment and blood in the eye, and you can completely lose the vision, not just only the vision, but also the eye. Um, and that's something to be aware of. That's probably what I'm telling you, worst case scenarios. And the other things are you can lose the eye from a retrobulbar hemorrhage. That means during surgery, when they're removing some fat or even just the muscle, it can bleed a lot, and you can go have the blood go behind the eye. And if you put too much pressure on the eye for too long, you'll permanently lose vision. And unfortunately, it's happened in our with blepharoplasties. Not as much with people specialized in it, but it can happen, and I've seen it reported. And if it's not taken care of within a certain amount of time, you can permanently lose vision. And so I always ask people, are you on blood thinners? Are you predisposed to bleeding? Try to not do anything with a lot of straining so that you don't accidentally burst a blood vessel or something after surgery. So I do a lot of things to try to prevent that kind of a scenario. The knock on wood, never had it happen to any of my patients. But I always educate on those things so they know to call right away, because I have had patients come in from other surgeons who didn't know to call, and they thought they could just get vision back, and once it's lost like that, you can't get it back. So
So
uh,
you obviously know how to avoid it, and you would know how to treat it if it happened.
yeah, yeah. But again, you have a time limit. So that's why I tell everybody, call within a certain amount of time. I mean, same thing with like fillers. Every year we see at least a couple, and then we probably have a handful in the LA area of people who have had fillers go into a blood vessel around the eye, and they end up seeing us, in ophthalmology, right? People, I had this poor girl who had PRP injected in her forehead, and she fainted at the time, completely lost vision, got vision back in one eye. And she went to the hospital, but they for some reason thought it was just orbital cellulitis or something, just gave her antibiotics, didn't even know to try to give her hyaluronidase or treat her as a stroke. And she basically completely lost vision. The eye swelled up over the first few days, and then gradually it didn't have any perfusion of blood to the whole eye socket, that the eyeball shrank down. It became this little icicle eye. Um, it became a shriveled eye, and then even the fat around the eye atrophied. So her eye, everything sunk in. I think we just published it as a case report, so people are aware of that kind of situation. But now I've kind of reconstructed her with basically giving her an artificial eye. I've actually injected more filler to fill that superior sulcus, all that hollow, to replace some of the fat. And she has droopy eyelid now, so ptosis. So I'm also fixing her ptosis that's happened. Finally, this Christmas, she came to me happy. She looks good enough to be in her Christmas photos again. I mean, this is somebody who was beautiful to begin with, and she just wanted a little wrinkle taken care of on her forehead with PRP, and it just became this disaster this past year. And now and that happened just before Christmas last year, and now this Christmas, at least she doesn't have a seeing eye on that side, but at least we can give her a normal looking eye So yeah, these are the kind of things that I get to deal with. Those are what walks in my door sometimes.
Well, that you always get the most challenging cases because of your
Yeah,
specialty. You don't
right,
get
right.
necessarily the easy things, you get the more challenging things.
Yes, yes, for
So,
sure.
in
And
terms of surgery, beyond eyelid surgery, what are the most likely procedures that are to combine with eyelid surgery, such as brow lifts or
mm.
rhinoplasties, or what are the other surgical procedures that are most commonly paired with the eyelid surgery?
Oh yeah, my most common is just eyelid and brow lift at the same time because really, but a lot of people come to me and they say, I got droopy eyelids, and I have to point out to them, at least half of that is from your brows also falling into your eyes, and so the brow lift. My happiest patients are the ones who get not only the blepharoplasty but also the forehead lift, and they just look like they finally got a good night's rest and they look awake and you can see their beautiful eyes again, before they were hidden, so they can see better, look better, feel better. That's my, motto for
So,
patients. So that's my most common
so when you do the
combo.
forehead lift, do you generally do the incision above the hairline?
Hit.
Is that a general
Yes,
rule?
hidden. Yeah, my preference is to do hidden endoscopic. So I'm starting the incision probably like a centimeter behind the hairline. They don't lose any hair. People always ask that. We don't shave their head or anything. It's all hidden. But if someone has a long forehead, I will actually do like a pretracheal incision, and kind of shorten their forehead at the same time. So I just did that for a patient. She looks fabulous. And yeah, so that's my most favorite combo. The other thing I add to that is I tell them, gravity keeps working. You keep blinking, things can shift downward. So we try to minimize the recurrence by I do a little neuromodulator, brow lift and prevention as well. So I'll focus on the muscles that are pulling the brows back down again. And I tell them you do it at least once, just before surgery or right after surgery. So as you're healing, your muscles aren't going to be pulling your brows back down. So we maximize the longevity of that surgery. And I recommend continuing to do it to keep the effects going longer, so that hopefully they don't need another surgery for at least another 20 30 years down the line if they're maintaining it with some neuromodulators. So, the thing I tell them that I can't do is I'm fighting gravity, but gravity is always going to win. So they can't really sleep upside down like Batman. But the thing we can do is minimize the muscles pulling everything down. So I always add a neuromodulator at the time of surgery or before. And then sometimes we'll combine with fillers afterwards, because the cheek, like I said, remember the cheek bones and fat go back as well. They descend and deflate, right? So we want to fill that space up sometimes with fillers. We could do mid facelift. Sometimes we'll do a fat transposition and use some of the fat underneath the eye and transpose it under that tear trough ligament. Or we'll do fat transfer. So a transfer fat from their belly into their face and revolumize the face at the same time. So those are all other fine, great combos.
Wonderful. So upper eyelid surgery, tell us about cosmetic versus functional, and
Hmm.
do cosmetic and functional eyelid surgeries really differ? And really, how do you approach these procedures differently?
Good question. In my hands, they do not differ because my goal is the same for everybody, whether they're functional. Everybody wants to look better, right? It's a matter of who's paying for it, really. And for insurance to pay for a droopy eyelid surgery, there has to be enough obstruction. Either the eyelid is going down, so the weight of the skin will weigh down the eyelid and cause ptosis. And if it starts to obstruct or starts to get close to the pupil and obstructing their superior visual field, we do a visual field test, and also photos to show that it's getting really close to the pupil. Then insurance may cover the blepharoplasty. But if it's less than that, then they're just paying it out of the pocket. But my goal is still the same, whether no, it's just a matter of who's paying, the patient or the insurance. And sometimes we'll combine it so probably my most common thing is their droopy eyelid may be bad enough that the insurance will cover the eyelid part, but then, like I said, they're not necessarily going to cover the part that at least 50% of the contributions from that brow coming down. So then we'll add on the brow lift at the same time, and that's out of pocket. So and I have a few like older people who I'll do functional brow lift where I can basically make a cut right at their brow and I'll lift that as well. And some of the guys, they don't mind that little scar, but they'll need that for functional reason because that brow is so low that it's pushing down and covering their lateral peripheral visual field. And so if we can show that, then we can get insurance to cover that type of brow lift. It's called direct brow lift. So, and then that's should be covered for functional reasons because it's helping them drive better because it's expanding their peripheral vision as well.
And so because you're such a very high level academic center, would a high percentage of your patients be insurance patients, or would many of them be elective patients?
Yeah, it's a mix. My most common are the people who have a mix. They'll come with some their droopy lids are usually bad enough for insurance coverage, and then we'll add on a cosmetic blepharoplasty, the lower lid fat bags at the same time, or add on the forehead lift, or they come for just ptosis and something's wrong, but they also want a cosmetic improvement of their eyelid, and then we have an additional. So that's probably my most common is a mix, but I have pure cosmetic as well, where we're not dealing with insurances at all as well.
Mm-hmm. And I know we covered a lot of this, but I'm just going to recap and ask you one more time, just go over what is ptosis and basically how it impacts vision or quality of life. Give us the short version of that.
There's a few types of ptosis, and the most common one we've been talking about is ptosis of aging, or what we call aponeurotic ptosis, where the eyelid lifting muscle just kind of stretches back and the eyelid just kind of droops more and covers more of the eye. But there are other types of droopy eyes that we have to be aware of. So like there's myogenic ptosis, which is the muscles just not working well, like myasthenia gravis. It can cause droopy eyelids, and that type of droopy eyelid is fluctuating, so it gets worse at the end of the day. We do an ice pack test, and it opens up better. So that's a kind of a functional thing. And that can be treated with a drug called Mestinon, or a cholinergic type of. There's medications to treat that you need to be aware of. And then the scary type of ptosis that everybody also needs to be aware of is like from a third nerve palsy, or like where there's an aneurysm or dissection of the carotid that can cause a ptosis. And that kind of droopy eyelid is actually a medical emergency that needs to be seen in the ER and treated right away before that aneurysm ruptures or dissection occurs. So yeah, there's lots of types of droopy eyelids, and some are actually a sign of a scary thing and need to be addressed. If it's sudden or and it comes with a headache, or there's some sort of change, then definitely that's actually an emergent condition.
So what are the major lifestyle things that people can take to reduce the risk of developing droopy eyelids? I guess I'll ask the question the other way. What are the major lifestyle things that you see that lead to droopy eyelids? Is smoking a risk, or what are the risks?
Smoking makes everything worse. Yeah, including thyroid eye disease. But actually, one thing people are not so aware of is the way they're sleeping. So I look at somebody, and I must always can tell if they have a favorite side that they sleep on.
Really?
Because the side that they sleep on tends to be the droopier side.
Wow.
I'm very good at assessing that. I'll ask them, "Hey, are you a right-sided sleeper?" And they'll think about it. Like, yeah. How do you know? Well, I can see the facial changes that have occurred in your face over decades of sleeping preferentially on one side. You can see that side will droop more. The brow is lower on that side. The eyelid is lower on that side. You can see that change. So I always encourage people, if they can, to sleep more on their back. And you can even have the bed elevated a little bit if you want, but yeah, more on your back if possible. The other thing tied into that is sleep apnea. Sleep apnea will cause something called floppy eyelid syndrome. So that will cause ptosis because what happens is, they have a floppy epiglottis and they'll cause them to snore. They don't sleep well. So they tend to sleep on their front, okay, which you already know is going to make things more droopy. So they tend to sleep on their front. And then sometimes the sleep apnea is so bad that it keeps stretching the eyelid and pulling it as they're sleeping on the front. Sometimes it will actually flip inside out, and that inside part of the eyelid will stick to the pillow. And then so they'll come with this really irritated eyelid. It's swollen, thickened, and floppy. You pull up their eyelid and you can see like all the way up into the fornix. Like it's almost like you can look into their brain by pulling up their eyelids. It's that floppy. And then because it's been so stretched out after all these years of doing that, it gets droopy. And so those people with floppy eyelid syndrome, we have to actually cut out a chunk of their eyelid and have them sleep with an eye shield. I mean, it's a biological problem, so we can't keep cutting out eyelid. They need to figure out how to, get their sleep apnea treated, sleep on their back, and then I have them sleep with eye shields. And once that's stable, then I'll do their ptosis surgery and open their eyes so they can see better.
So when you see somebody, can you predict at a young age that they might be at high risk for, when you look at, say, if you look at somebody's photos when they're younger, could you predict that they might be in their youth, might be a high risk for getting droopy eyelids when they get older? Can you predict that?
Well, I actually see a lot of younger people who've had kind of a mild congenital ptosis their whole life, and they are able to compensate for it for a while until they get older. Like I'll do like 18, 19, 20-year-olds who've had a little bit, not severe congenital ptosis that they need fixed when they were super young, but that it wasn't bad enough for them to do anything about. But it does get worse as they get older. So uh, I have to correct the congenital ptosis, mild congenital ptosis, fairly early on. That's probably the easiest if you see a little bit of droopy eyelid. And then sometimes just the structural anatomy, you can see like low set brows. They're the people who are born with low set brows tend to have, even worse low set brows as they get older, and those folks need more eyelid surgery and the brow lift even younger in life.
I'm of Irish descent, and a lot of my relatives they've always had these congenital or born with droopy eyelids. It's common in the Irish.
Yeah.
Rhinoplasty. Tell me about rhinoplasty, nose surgery, and under eye bags. Why do some rhinoplasties develop more pronounced under eye bags, or do you notice that they develop more over time? Is it something you
Yeah,
notice?
I don't. You pointed that out to me actually from your experience, which I thought was interesting. I think one of the reasons I saw a patient that had they could not actually close their eyes very well after a rhinoplasty because the surgeon did what they call them, like a high osteotomy. And so, because they have to break the bone sometimes to reposition it. And sometimes they'll get into the orbicularis muscle that closes the eye. And that's the muscle that squeezes the eye shut. It's also the muscle that holds the eye bags back. So if you weaken that muscle, it makes sense that the eye bags can come forward a bit more. The eyelids don't close as well. So that I think is probably a more rare side effect of rhinoplasty. I don't think it's not too common that I see that, but there is that potential, I believe, with rhinoplasty.
So I think that wraps it up. Well, thank you so much for sharing your expertise and your insights today. And those interested in learning more or scheduling a consultation, where can they find you?
Oh, they could probably Google me, but I don't really I'm not great at maintaining like a private practice website, but they can probably find me on my Instagram DM DRZHANGNUNES, Dr. Zhang-Nunes, so DRZ Zhang-Nunes, all one word, no hyphens. On Instagram to find me there, or you can Google me and find my office phone numbers with any questions.
At USC.
Correct. Yes.
Mm-hmm. Well, thank you so much. That wraps it up.
All right. Thank you for a fun, enlightening conversation.